URL आप हाय डॉक्टर रियाज।
हाय सुशांत, हाय, हाउ आर यू?
आई एम गुड, आप कैसे हैं?
बस बढ़िया बढ़िया, बताओ।
हाउ वाज योर सैटरडे ओपीडी?
अभी एक ऑफ की है, नहीं है, ऑफ तो नहीं है अभी, जस्ट ओपीडी बंद की है। एक
हाँ
मीटिंग में चला गया था।
हाँ
एक
हाँ।
कब था, अभी बस लौट ही रहा हूँ ऑन द वे।
अच्छा,
तो गाड़ी
फिजिकल
में
मीट
बैठा
से
हूँ।
वापस आ रहे हो?
हाँ, फिजिकल मीट से वापस आ रहा हूँ, चलो।
ओके
तो
ओके
मैंने
ओके।
ज्वाइन कर लिया, गाड़ी में बैठा हूँ, होपफुली
हाँ, तभी
फाइट।
मैंने आपको हेलो भेजा, मैंने कहा आप ज्वाइन हो रखे हो,
हाँ हाँ
जब
हाँ
तक
हाँ
स्टार्ट नहीं होता।
हाँ
और
हाँ
आपका
हाँ।
हाउ इज ट्रांसप्लांट यूनिट गोइंग ऑन?
बस चल रहा है बॉस।
गुड। आप राजीव
हम
गांधी में हो ना?
हाँ, राजीव गांधी, मैं, डॉक्टर पुरानी, डॉक्टर नरेंद्र,
ओके
हम
ओके।
तीन लोग हैं।
चलो, वंडरफुल वंडरफुल, दैट्स ग्रेट। बोन मैरो ट्रांसप्लांट करना भी एक बड़ा वो है,
अरे, हेडेक है
टीडियस
यार।
जॉब है। हाँ
टीडियस
सच
जॉब
में,
है, हेडेक है। सही
टीडियस
बोलो तो
जॉब।
हेडेक है।
मतलब मैंने टीएमएच गया, मैं डॉक्टर नवीन खत्री सर के साथ
हाँ
था।
हाँ 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 हाँ
वो सर तो ऐसी मतलब रेल बनाते थे।
हाँ हाँ हाँ। तो वो काफी ये है, परफेक्शनिस्ट है वो।
सर अरे अमेजिंग, सर ने 3 महीने ऐसा ट्रेन कर दिया था।
हाँ हाँ हाँ
सर मतलब कहते थे भाई रात को 2:30 बजे भी अगर पॉटी हुई है ना, तो जा देख क्या
हाँ
कौन से कलर की पॉटी हुई है पेशेंट को, वॉमिट हुई
हाँ
है तो
हाँ
कौन से कलर की वॉमिट हुई है, सब
हाँ
सब कुछ। ही इज वेरी मेटिकुलस
हाँ,
इन
वेरी
दैट।
मेटिकुलस, या या।
वेरी मेटिकुलस। इसलिए गुड। तो आप कहाँ रहते हैं डॉक्टर यार?
मैं रोहिणी में रहता हूँ, सुशांत, रोहिणी सेक्टर
अच्छा।
29, पास में ही है
ओके।
हॉस्पिटल के, नॉट बैड, 15
हाँ
मिनट्स
हाँ
फ्रॉम हॉस्पिटल।
हाँ, दैट्स वंडरफुल। मैं भी पश्चिम बिहार में रहता हूँ।
ओके,
हाँ जी।
दैट्स ग्रेट।
तो मतलब अगर यूरोप होता तो शायद मैं वॉकिंग ही चले जाता हॉस्पिटल।
वॉकिंग, हाँ।
लेकिन हिंदुस्तान में वॉकिंग मुश्किल है।
हाँ, मुश्किल है। मैं भी हो सकता हूँ, यूरोप होता तो शायद साइकिल से आया रहता।
हाँ, वो एक्सरसाइज भी हो जाती है और कर
आई
भी
वुड हैव कम।
काम भी कर रहे थे। यस
हाँ हाँ
डेफिनेटली।
हाँ, ना वो कॉन्शियस था ना, साइकिल से आ गया। द डॉक्टर हैज
हाँ।
कम ऑन हिज बाइक। ओके, तो यहाँ पे मुश्किल है।
यहाँ पे मुश्किल है। मैंने कोविड से पहले 1-2 हफ्ते ट्राई भी किया था, मैं साइकिल से गया था, वो गार्ड भी हैरान हो गया, कहते डॉक्टर साहब क्या हुआ, गाड़ी को क्या हो गया? मैं कुछ नहीं हुआ भाई, गाड़ी को कुछ नहीं हुआ।
अभी भी चला सकते हैं, पर वो ना फिर डर वो टू व्हीलर्स वालों से लगता है मुझे।
हाँ सर, गाड़ी
वो,
चलाने वालों को ना टू व्हीलर वालों की वो नहीं होती।
हाँ हाँ हाँ,
और
चाहे वो
स्पेशली
अब,
साइकिलिस्ट साइकिलिस्ट की तो होती नहीं, हटा सावन की घटा
हाँ
वाला हाल
साइकिलिस्ट,
है।
हाँ हाँ हाँ, मतलब वो तो दे डोंट इवन एग्जिस्ट।
दे डोंट इवन एग्जिस्ट।
हाँ, श्योर।
सर
तो
सिक्स
अपनी
थर्टी हो गए हैं, आप बोलो तो स्टार्ट कर दूं इफ यू आर रेडी।
जैसा जैसा बोलो। If
नहीं
you want me
आपको
to
अगर,
start or five, you tell me 5 minutes to 5 minutes. I can wait.
हाँ पाँच
People
मिनट
have
में
joined.
स्टार्ट करते हैं। हाँ मैं
5 minutes.
देख लेता हूँ, हाँ 5 मिनट
Sure,
में
sure,
स्टार्ट।
sure.
ओके।
Okay. Hello.
So, good evening, everyone. I like to welcome you all on day 2 of hematological update. And I'm sure that just like yesterday, today is also going to be an academic feast for everyone, including the audience, the panelists, the PG students, everyone. And I am really honored to welcome back once again Dr. Riaz Ahmed, who is a senior consultant and a hematologist at reputed Rajiv Gandhi Cancer Institute. And he'll be talking about management of mantle cell lymphoma, the first relapse. As we all know, mantle cell is a big spectrum of disease ranging from indolent disease to aggressive. So how the patient is to be treated in the first relapse, we'll have a talk by Dr. Riaz. Welcome, Dr. Riaz. Over to you.
Hi. Good evening, everyone. So, give me some time. I will start sharing my slides. Sure. So, I hope my screen is visible on. And let's start. Okay. Good evening, everyone. So, I've been assigned this topic of mantle cell lymphoma in first relapse. So, to just start the talk, we know that mantle cell lymphoma, non-curable type of disease, behaves aggressively, but as the low-grade lymphoma, you cannot cure it, and we have to start with the induction treatment, go for the transplant for transplant eligible, or give them the consolidation and followed by maintenance to have that progression-free survival increased as much as possible. So, different authors, means mainly the three people I have known, I have been following them, is Dr. Michael Wang, Dr. Chisen, and lately Tobiar, with this. Those who have been, whose work in the mantle cell lymphoma, we see them quite often. They are the part of mantle cell guidelines. So from where they will say that, okay, this is the way to go for mantle cell lymphoma. So what we were using our job lately have been treated the role of high-dose Araci, lately the effect of lenalidomide, bortezomib, and finally that what we know is ibrutinib. This all has been made possible by the work of these gentlemen. So this was in the article given by Chisen. He has that if the patient has relapsed.
Dr. Riaz, sorry to interfere, but your slides are not visible as of now.
Okay, I'm sorry. I'll just try again. Just give me 2 minutes.
Yeah.
Is my screen visible now?
Yes, they are visible now. Yes,
sure.
Wonderful.
So this was a trial. This is a paper given by Chisens that yes, when the patient is relapsed, you assess initially whether for trial or not for trial. That's the time when ibrutinib just came into picture, whether patient is eligible for transplant. If it's not, then if ibrutinib is available to you or not, and it's not contraindicated. If yes, it's available, start with ibrutinib, and followed by you go for, if not transplant eligible, you go for then bordex, if it is the patient are not fit for bortezomib, something like that. So finally you end up doing allogenic transplant or CAR T lately for this. So this is the 2020 guidelines for the relapsed refractory guidelines for mantle cell lymphoma. We see the partial lot of regimens here. Partial response with intention to proceed to transplant. You have bendamustine rituximab if previously not used, bortezomib with rituximab, and lenalidomide with rituximab and R-CHOP if it has not been used, or VR-CAP if not used. Short duration of prior chemoimmunotherapy, that is less than what's expected median PFS. You have BTK inhibitors like acalabrutinib now, ibrutinib plus minus rituximab, zanubrutinib, and lenalidomide plus rituximab, venetoclax. So these have been there, and we have to juggle which is our. So in this talk, we'll try to get it okay what our options are, what we can do for the mantle cell lymphoma when it's relapses. So this is the one basic slide for where we say, okay, first line we have these options. We know the effect of Aracy in upfront setting, effect of autologous transplant, and followed by maintenance. So these three things have really changed the progression-free survival, the management of mantle cell lymphoma. Finally, one, if what if the patient relapse? So you have these options. Now you have ibrutinib, you have acalabrutinib. Zanubrutinib is not still available with lenalidomide. With rituximab, we have venetoclax. Yes, we have the generic version and the from the gray market, and bortezomib plus rituximab and alternative chemoimmunotherapy if you have this. So let's start with lenalidomide in refractory relapse refractory mantle cell lymphoma. So this is the sprint study. They enrolled this 25 milligram of lenalidomide 21 days every 28 days until progressive disease was a single agent investigator choice treatment. Either it is rituximab, gemcitabine, fludarabine, chlorambucil. So this was in the late 2009 until 2013, and finally they were able to say in relapse setting, you have got a progression-free survival, which is little better than the one what the compared to what the other other arm from the lenalidomide. So you have this survival, although almost similar, not changing over a period of time, 27.9 versus 21%. Yes, so the role in the relapse setting, if lenalidomide was, yeah, you can have this. The response was better than the other agent. The hematological in the what you have the adverse events in the hematological settings, the anemia, thrombocytopenia, much more in grade 1, grade 2, and leukopenia, not much there, and febrile neutropenia with lenalidomide was not there even in the investigated, the whatever the other agent was, it's okay, but the hematological profile was much more severe in the lenalidomide arm. Now again come the phase 1 phase 2 trial of lenalidomide and rituximab in relapsed refractory mantle cell lymphoma. So 44 patients were enrolled. Overall response rate was seen in 25, with you have 16% who had shown the CR rate with partial response in 9. So much addition of rituximab did make difference to having lenalidomide alone. And median duration of response was 18.9 months, and median progression free survival was 11.1 months. Overall survival median was 24.3 months. So time to first response was around 2 months. It ranged from 2 to 8 months, and the best response was around 2 to 12. So this is the overall picture. Not bad for a relapse setting. And this was the trial when I remember that when your ibrutinib was not available. Ibrutinib was not available. So what to be done? R-CHOP given. What next? Either you go for high dose salvage therapy. People never used to tolerate that when if you have then came the lenalidomide setting. So this was those era 2009 2010 when ibrutinib was not available with us. Now, in coming to the BTK inhibitors, ibrutinib. So this changed quite a bit in the management of mantle cell lymphoma. So this was published in 2013, and targeting BTK with ibrutinib in relapse or refractory mantle cell lymphoma. And here they classified in the two groups: the patient who had been treated with bortezomib or those who have not been treated with bortezomib prior. So divided into equally into two groups of the patients, everyone matched to their respective variables of age, sex, ECOG performance, and previous therapy, whether it's hyper-CVAD or stem cell transplant or received lenalidomide or rituximab lenalidomide, much better. Even in the MIPI risk stratified area, low risk, intermediate risk, or high risk group. Now, the best overall, you can say, those who have not received no prior treatment with bortezomib, the total number of patients was 63. Overall response rate was 43%. The complete was seen in 12, partial rates was seen uh, in 31% of the patient. In the prior treatment with bortezomib, complete response was seen in 12 and partial in 21. So this was the much better progression-free survival. Those who had prior treatment with bortezomib scored with 16.6 versus 7.4. Those were no treatment with prior bortezomib. So this is the median progression-free survival according to the bortezomib or no bortezomib exposure. You can see that blue line in the Kaplan-Meier graph is what the bortezomib exposure has been there. And yes, those who are exposed did better than what the no bortezomib response was there. And when you combine everyone, you can see it's coming in between. So the median progression-free survival, those who had a partial response at the best response was 17.5 months, and median PFS among the patient with CR was had not reached. So was the one abrutinib which said, okay, around 50% of the patient has gone into remission. They have achieved some or the other response, and at the end of even 1 year, those people remained into remission. That quite a breakthrough, ibrutinib coming in for the mantle cell lymphoma. And overall survival also much improved around whether it's you have bortezomib exposed or not bortezomib exposed, around 60% of the patient had survival around at the end of 1 year were surviving. So that was good. So ibrutinib in this the adverse event, coming to the adverse event, what we had is most of the patient of any grade of diarrhea in 54 and fatigue in 50 and dyspnea in 32% of the cases. So not much. And the most common hematological adverse effect was in the range of 10 to 15% from anemia, thrombocytopenia, neutropenia being 17%. So infections all grade 78%, bleeding 50%, and the cardiac was 11%. So yes, not much, manageable. And it did change the management of, this was the first one which actually changed the management of relapsed mantle cell lymphoma. Now came the acalabrutinib. So acalabrutinib have recently been launched, that Calquence, and this is a ACE like 004 study, open label phase 2 study of acalabrutinib in relapsed refractory mantle cell lymphoma. So in overall 124 patients were enrolled, and acalabrutinib was given 100 milligram twice a day in 28-day cycle until the disease progression or unacceptable toxicity. So in this, you can see the best overall response was seen in 81% of the patient initial analysis of 15 months follow-up. CR rate was seen in 40% of the patient with partial response in 40. So yes, stable disease in 9. So most of the patient, 80% of the patient either had partial response or CR. So much better than ibrutinib. And when they followed up to 24 months of this data, so it came to the CR rates remained at the 43%, and the partial response a little bit 30%. So that maintained that response we had with the acalabrutinib is for a longer period of time, and in this 80% of the patients group. So when they followed up the progression-free survival, you can see almost 40% of the patient, the PFS at 21 months was around 27.7. That's quite impressive. 24 months, about 49% in 50% of CI. So that's the great one effect better. So you have a patient, if you can juggle between ibrutinib and acalabrutinib. We have used acalabrutinib lately in a few of our patients, and the responses, even all the patients in which we have used acalabrutinib were either ibrutinib exposed. So our best response, even if they are previously ibrutinib exposed, was the best response for the duration of response was around 9 months. So this second generation ibrutinib BTK inhibitors did wonders for us. So when we followed with the overall survival data, then we have median overall survival of, it's not reached, but if you can see that 24 months overall survival 72%. So that's very impressive. That's really impressive for the acalabrutinib study. So this is the summary when we compared for the same study, PFS versus OS. have the what we discussed right now. So the third drug, it's still to be available in India, zanubrutinib. This is also coming with the quite the results which has been shown in the trial is much better. Number of patients enrolled in this study are 86 with you can see CR rate in almost 15% of the patient with partial response in 69. And when we had the updated progression-free survival, almost you can see at 12 months, 70% of these patients were had this progression-free survival. So this one more drug to in our kitty if we have this patients, and this you can see the patient with MCL and more than one prior lines were used. ECOG performance was okay, 0 to 2, and no notable cardiovascular disease and no prior. The only thing is that they have no been exposed to ibrutinib previously. Now, so this is the comparison between the all three BTK inhibitors what we have: ibrutinib, acalabrutinib, and zanubrutinib. And you can see the neutropenia is much more in ibrutinib compared to the acalabrutinib or zanubrutinib. Infections are more common in the acalabrutinib according to the data, 20% of them, and bruising and hemorrhage is more common in our ibrutinib arm. So 4%, and the zanubrutinib also we have the same as 5% of that. This the comparison almost you can have, and the lymphocytosis was seen almost similar in all the arms with 41% leading in the zanubrutinib. So this is the relative comparison. So we have, if it comes, so once the relapse setting in our setting, what when the patient has relapsed after the initial, either you use VR cap or with high dose RC, or you have used R-CHOP and patient has relapsed, whether patient has received autologous transplant or not, or rituximab maintenance or not, you have this BTK inhibitors. So this is the summary of what we discussed. Different trials has been done in different setting, phase 1, phase 2, and the pool data, and everyone has almost given the same results of response rate of 60 to 70% and CR rate of 20%. Everyone has given in the same settings, and we have this neutropenia, thrombocytopenia, almost everyone, but manageable, not much. Now, this once happened, so they started combining rituximab in combination with rituximab in relapsed or refractory mantle cell lymphoma. This was by Michael Wang again in the phase 2 trial. And in this, what they could find is they enrolled 50 patients, and the objective response was seen in almost 22% of the patient, with patient achieving complete response, and 22 had the partial response. So that's quite impressive. Out of 50, when you combine, the 44% have overall response rate with equally divided with the partial response and complete response. And it was quite well tolerated in the patients. And so having rituximab combination with ibrutinib, all the is adding a much better response with limited toxicity. So, and again, going one step further, whether ibrutinib, rituximab, and if lenalidomide is combined in relapsed or refractory mantle cell in Philemon study, the multi-center open-label single-arm phase 2 trial. Again, so here what uh, between 2015 and 2016, again 50 patients were enrolled, and after the follow-up of 17.8 months, patient had an overall response, including 28 who had complete response and 10 had a partial response. So out of 50, 38 people responding, that's even not bad. That's you can have remember this, it has also refractory patients. It's not the first relapse only. So the data which I'm able to collect, which I'm presenting you, had the refractory patients. So it's a triplet combination, multi-center trial, although phase 2, it gives that even if you combine ibrutinib with rituximab with lenalidomide, much acceptable toxicity, and you have a response rate of almost 38 out of in the out of 50 patients. Now newer things which have been there is a ibrutinib plus venetoclax for the treatment of mantle cell lymphoma. So again, this venetoclax is a new kid in the block. Almost this drug has been used in multiple hematology setting, in leukemias, in lymphomas, some or the other. Everyone is presenting. Okay, what they are able to do what the venetoclax can do to their study. The rate of complete response assessed by the PET was about 62% at 16 and 71% overall response rate, and the MRD clearance was confirmed by flow cytometry in 67% of the patient. So the combination has given almost seven, can say at week 16, 62% was PET negative. That's great. So if we are able to use this combination, so especially the patient who had TP53 mutations, you can get better clearance. So this is the list of all the combination covalent gluten kinase inhibitors based combination when you have ibrutinib plus rituximab or ibrutinib and rituximab or ibrutinib venetoclax or obinutuzumab is the one ibrutinib plus bortezomib. So these are different combination. Everyone showing almost all the major responses I have just covered, and this is the collection of this all these studies. Now, coming to the CAR T, what we have in the refractory, we know that mantle cell lymphoma patients, we cannot cure them. Apparently, we are trying to have increase their progression-free survival. So this is the one Zuma-2 study of gene Alucil in relapsed refractory, and this ongoing, was successfully manufactured in 96% of the patient, administered in 92%, and median time. So this is the CAR T and much anticipated what you say the results hopefully in the coming ASH meeting we'll have this CAR T sessions of mantle cell lymphomas, and this the more the outcomes from different centers will come to know. So in this CAR T you can see the best responses. You are seeing the 40% of the patient had CR and 16% of the patient had PR, and overall survival you can see in the range of 75%. So that's one of the things with the CAR T yet to come in India, but still a patient who can afford, and it's a new thing which may be available to our country in future. So coming to that's what we do now, what the algorithm we are going to have. So if the patient is trial eligible, looks like likely that poor response to proton kinase inhibitors or the pleomorphic morphology or TP53 mutation. So if you say yes, then go for CAR T. If it is no, then you can plan for second generation acalabrutinib or zanubrutinib. If still it is having progressive disease, finally you have to move for CAR T. And even if your CAR T it's suitable, you give the Bruton tyrosine kinase inhibitors for bridging, and finally go for the CAR T. So this was the one of the progress sheet given by one of the authors. This is Toby Ayer paper in the blood. Now this is the one what we say. Okay, in India we have to make our own algorithms. We have got limited availability of drug, and the finances we have to take into. Not everyone will be recommending acalabrutinib. We cannot say everyone has to take acalabrutinib or zanubrutinib, which is not available. So this is the one of the patient is high risk, or the patient of disease is less than 24 months from the front line, or it's a blastoid morphology or TP53 mutation. Consider BTK inhibitors, whether it is ibrutinib or first generation or second generation. If achieving CR or PR, continue BTK inhibitors or consider CAR T. And if the patient has not received autologous transplant, please consider, or patient has relapsed post-autologous, consider them for, if they have received even partial response, consider them for allogenic stem cell transplant. Or if the patient has relapsed over 24 months, reintroduction of Bruton kinase inhibitors, or you can change the from first generation to is a good idea, and continue indefinitely till the progression. And finally, if it is transplant eligible, go for the allogenic transplant. This is another thing in the when if you don't have CAR T, is one of the area. So with this, I like to close my thanks and will like to hand over this to organizers. Thank you for patient listening.
Thank you, sir, for a wonderful talk. It was indeed very lucid and comprehensive to understand. What I want to know, sir, is how is your personal experience with ACAL?
For acalabrutinib, yeah, Calquence, we have used in patients. We are when it was launched. I think so. I was behind AstraZeneca calling when you are launching. Yeah,
Yeah, yeah.
6 to 9 months. Patient has received ibrutinib. Still, the second generation when we used it, the duration of we got the response in everyone, and the time to response was around 1 month to 2 months, and the longest is of the patient in on acalabrutinib is 9 months. Okay, so the generic one is available now. The Calcans is available. So I won't go into detail, but the longest was 9 months. But eventually they lost. And remember, my all patients were already exposed to Bruton tyrosine in that ibrutinib they were exposed to. So the patient who are on first relapse, and if they can, I will say a little better. The response duration of response is little longer for acalabrutinib than ibrutinib. But India, I think so, more than medical, I think so, it's the finances which play the role. I'll not say don't use ibrutinib. Ibrutinib, yes, and please consider the dosing of ibrutinib also. People tend to take underdose themselves. If we do proper dosing and follow them regularly, I think so that is also still one of the best options available to us.
Thank you, sir. Thank you so much.
Thank you, Srikant.
With this, I would now like to invite Dr. Novak. He's a dear friend and medical oncologist at ESI Faridabad, and he'll be giving us a talk on role of second generation BTK inhibitors in management of CLL. Welcome, Dr. Novak. Over to you.
Uh, Good evening, Dr. Sushant. Thank you for this opportunity. And I'll start sharing my screen. Just a second. Yes, so is my screen visible?
Yes.
Yes, sir.
Okay. So first of all, I'll regret, I'll not be able to do justice to this topic. This is something really promising. I had to, I prepared the slides in a bit of a hurry. So anyways, we'll continue. So the role which is given to me is the role of second generation BTK inhibitors in the management of CLL. So I'm Dr. Nova Gupta from ESI Medical College, and talking about CLL management, it basically depends upon a number of factors. I think we're all aware, we can have various kinds of patient characteristics, the comorbidities, the frailty, the age, the younger patients, the older patients, various comorbidities associated with the older patients, the tumor characteristics, the type of disease biology, the patient preferences, the finances of the patients, the goals of the treatments. So treating a patient with CLL, unless a transplant is not being considered, how do we sequence the various therapies? How do you number of factors come into play? So talking about the disease biology, which I think now is something very important. And if we see the patients who are very high risk, these are the set of the patients who have a 17p deletion with or without a TP53 mutations. Now these are the set of the patients who would relapse, who would not respond or relapse very soon when these patients are treated with a chemoimmunotherapy based treatment. So by far, whenever we do see such kind of such patients, treatment with these targeted agents is the preferred way forward. The second set of the patients is the high risk patients, where the patients have a IGHT unmutated without a 17p deletion or TP53 mutations. These set of patients also they usually respond to the chemoimmunotherapy based regimes. But by far, again, for these patients also, targeted therapies are the preferred choice because of the improvements in the PFS, and there's some OS benefit which has seen in some of the trials. The next set of the patients is the standard risk patients who have IGHV mutated without a 17p deletion or a TP53 mutations. Now, when we talk about these set of patients, the PFS and OS, either these patients are treated with targeted therapies or the chemoimmunotherapy would be the same. But what we are seeing that, there's a set of the patients who have a IGHV mutated. Now, these patients, when treated with chemoimmunotherapy based treatment, some of these patients go into durable responses, which kind of suggests that, a cure has been attained. Now, everywhere, uh, we have lots and lots of options for our patients. It's a very good thing that, having so many options, but then again, the complexities of all these options also come into play. Now, as of now, what are the options which we have? We have the BTK inhibitors, the ibrutinib and the acalabrutinib, the BCL2 inhibitors, the venetoclax, the monoclonal antibodies, rituximab, ofatumumab, obinutuzumab, the purine analogs, fludarabine and pentostatin, the alkylating agents, chlorambucin, cyclophosphamide, bendamustine. These agents can be used as single agents or in combinations. We have the first generation, which was the ibrutinib, which first came.
Hello.
Dr. Novak?
Am I audible?
Yeah, your voice is cracking in between. You lost you in between.
I think there's some issue with I've stopped my video. Probably there's some network issues. So, talking about BTK inhibitions, BTK basically the BTK activation leads to a number of downstream pathways are activated, which leads to cell proliferation, the increased survival, motility, migration, as well as cytokine production and antigen presentation. Now, ibrutinib helps to stop this downstream pathway and BTK activation. Okay, so first drug which came into play was the ibrutinib. This was initially approved by FDA in 2014 based upon a phase 1 trial. Now, in the patients who had been previously treated, CLL patients, ibrutinib showed a very good response rates of about 71%. That is when the FDA approved this drug in the patients who had already been treated as a second line agent. Now, later on, the Resonate trial was published, which also confirmed these results. And then we had the Resonate 2 of ibrutinib in the first line setting. Ibrutinib has shown a very good results in older adults as well as in the younger patients and also in the relapsed refractory settings. So, in the older adults, when we talk about ibrutinib, it's a single agent, is very efficacious. It is both the PFS and the overall survival when compared to single agent chlorambucil. It has improved the progression-free survival when compared with bendamustine rituximab. So also ibrutinib, when combined with obinutuzumab, has improved the PFS, especially when we talk about comparison with chlorambucil with obinutuzumab. Now, the results are quite good. There are the issues, the problems which are associated with ibrutinib is it's mainly, these we're talking about the patients who are old, the median age somewhere about 64, 65 years of age. Now these patients, most of these patients have some kind of cardiac comorbidities, and cardiac toxicity with ibrutinib is something which was we are kind of concerned when we treat our patients or offer our patients with ibrutinib. Now, why do these patients, there's increased risk of atrial fibrillation and hypertension. Now, why do these patients develop these, cardiac complications? We are not sure, but what's postulated is that it is probably because of the PI3K-AKT signaling pathway, or it could be because of the human, HER2 receptors, which is involved in the cardiac monocyte homeostasis. These are postulated mechanisms, but what is important is that with ibrutinib, there is these complications of atrial fibrillation and hypertension. Now, next is coming to the topic for today is the second generation BTK inhibitors, the most important of which is the acalabrutinib. The second generation BTK inhibitors, they're kind of more selective. So, it's kind of hitting the bullseye, and you get greater efficacy without lesser toxicities. So acalabrutinib, it does not target the EGFR or the ITK signaling, which is probably the reason why there is decreased cardiac toxicity with acalabrutinib as compared to ibrutinib. Now, what is the data? We have the Elevate-TN trial. This was a global phase 3 multicentric open label study in the patients who were treatment naive. There were about 535 patients who were old, or in case the patients were younger, they had to had frailty index of 6 or more based upon the various comorbidities which they had. Now, these patients were randomized into 3 arms with 1:1:1 to either receive acalabrutinib with obinutuzumab for 6 cycles and then followed up with single agent acalabrutinib, or these could be, the second randomization arm was only single agent acalabrutinib, and the third arm was for 6 cycles of chlorambucil with obinutuzumab. Now, what were the results? So at a median follow-up of about 28.3 months, the 2-year PFS was 93% with a combination of acalabrutinib with obinutuzumab, and it was 87% with single agent acalabrutinib and 47% with chlorambucil and obinutuzumab. Now, both the arms where acalabrutinib based treatment was used, the PFS was improved as compared to chlorambucil with obinutuzumab with a hazard ratio of 0.1, which is kind of amazing to see. Now, the 4-year follow-up data, which is presented in basically abstract form, it's reported that the PFS is of the order of 87 months, 78 months, and 25. Now, overall survival data is immature. We do not have the overall survival data as of now, but the estimated overall survival at 2 years is of the orders of 95%, 95%, and 92%. And the 4-year estimated overall survival obinutuzumab. This was 70% in both the arms which received obinutuzumab and 50% in the patients in the arm which did not receive obinutuzumab. The grade 3 or greater infections were more common in the patients who received acalabrutinib based treatment, which was about 21%, 14%, and 8%. The most common adverse event with acalabrutinib was infection, headache, diarrhea, and nausea. The additional toxicities which were present was atrial fibrillation, hypertension, and bleeding. Now, what are the questions which we have as of now? The problems with this trial was this was not designed to assess the comparison of how would the combination of obinutuzumab to acalabrutinib would increase the efficacy. The second thing is we do not have any kind of head-to-head comparisons of the combination of acalabrutinib with other targeted therapies. The third thing is we are, we do not know how do we sequence, what is the, the right way to sequence these agents. And the, lastly, I think the most important thing is we need a more mature and data for the overall survival to come. Yeah, and the other thing is, I think, which I found out was that there was, this is again a subgroup analysis, and this, I do not know whether this is would be relevant or not, but what they found was that the improved efficacy was not seen in the patients with deletion 17p or 17 TP53 mutation. As again, like I said, this is probably a subgroup analysis, and there was a small sample size because for this to come to. Now, this is another study. I think in the previous session, this was discussed. I'll not talk much about this. This was recently published. This was the ACL001. There were about 99 patients and 53 months of follow-up. So about 9 patients discontinued treatments. The overall response rates were of the order of 97%, with 90% partial responses and 7% complete responses. And toxicity is again, grade 3 or more toxicity, which is important. Infections were seen in about 15%, hypertension in about 11%, bleeding in about 3%, and atrial fibrillation in about 2%. Now, this is another study which I found was, quite interesting. This is again very recently published. This is a comparison of acalabrutinib versus ibrutinib in previously treated patients of CLL. So all these patients had a confirmed deletion 17p or a deletion 11. Now these patients were randomized 1:1 to receive either five patients in each arm. Now coming to the now, this is important. The all grid, the atrial fibrillation and atrial flutter was much more with ibrutinib, with 16% as compared to just 9.5% with acalabrutinib. Both the arms, I mean, the hazard ratio is 0.8. Now, treatment discontinuation, again, I think is important. About 15%, 14.7% of the patients in the acalabrutinib arm, the treatment discontinued because of the adverse events or the toxicity, whereas this number was higher in the patients who were treated with ibrutinib with 21.3%. Now the next, this was acalabrutinib. The second drug is the zanubrutinib. This is just we just brush up this. So there's a phase 1 trial. The response rates of the order of 96%. There's ongoing Sequoia trial. Some preliminary results have been published with the overall response rates. Now Sequoia is in the first line setting. Response rates of the order of 92%. There's another drug by tirabrutinib. There's just phase 1b study and response rates of the order of 83%. Now, this is the the toxicity profiles. This is again cross trial comparisons, the various trials which we have of all the three. I'm sorry, I cannot hide this. In all the three BTK inhibitors, thrombocytopenia was 29% and about 15% in both the second generation BTK inhibitors. Anemias, I think, is almost similar in all the three BTK inhibitors. Now coming to the GI toxicity, again, if we see the grade 3 or more toxicity, diarrhea was more with ibrutinib with 5%, and it was about 3% with acalabrutinib. Now the other toxicities, infections. If we see the pneumonias were higher with ibrutinib with 8%, and they were about 5% with acalabrutinib. Zanubrutinib is again the about 10%. So the other toxicities, if we see the fatigue and asthenia were higher with ibrutinib with 5% and 3%, which was very less with acalabrutinib with 0.8% and not reported. Rash was another thing which was important with ibrutinib with 3%, which was just 0.
Dr. Novak, we have lost your audio.
About 3% with acalabrutinib. How do you? What's important is to closely monitoring the patient. Second thing is antiplatelets or anticoagulants when required might be given. Only thing is be very apprehensive in advising a dual antiplatelet, especially when the patient is on BTK inhibitors. The third thing is, in case the patient is going for a surgery, it is better we stop this drug with 1 week prior and then 1 week later on. Second thing is the infections, the grade 3 or 4 infections. Now these are about 21% with ibrutinib, 19% with acalabrutinib. Again, monitoring the patients and any kind of antibiotic prophylaxis might be considered. The cytopenias is again kind of neutropenias, almost identical, 23% in both ibrutinib and acalabrutinib. Thrombocytopenia is almost 8% and 7%. Anemias is slightly higher, what this reports with the acalabrutinib. Now, just monitoring the counts is something important. Yeah, coming to the last thing, which is important, I think the atrial fibrillation and flutter, which is higher with the ibrutinib with 4%, and it is about 1.1% with acalabrutinib and 0.6% with zanubrutinib. Other malignancies is almost identical, 10%, 12%, 9% in all the 3 BTK inhibitors. Hypertension is higher with ibrutinib with 19%, and treating the patients with any kind of antihypertensives is important, and monitoring the blood pressure is again important. So with this, I'll stop sharing my slides and.
Thank you, Dr. Novak, for the presentation, and thank you for doing it in such a short time. I know you had a difficult time arranging the things, but thank you so much for such a great talk. With this, I like to now welcome Dr. Samit Purohit. He's a renowned medical oncologist at Action Cancer Hospital, and he'll be talking about chemotherapy-induced anemia. Over to you, Dr. Samit.
Thank you, Dr. Sushant. So I'll just share my slides. I hope my slides are visible now. My slides are visible, right?
Yes, sir.
Yeah.
Visible.
Yeah, great. So I'll be speaking on chemotherapy-induced anemia. And we know that 3/4 of our cancer patients will have anemia at some time during their illness. And among the solid tumors, around 56% and 3/4 of the hematological malignancies will have anemia. And in total, if you see 40% of these will have severe enough to warrant red blood cell transfusions. And in Indian context, these figures are likely to be higher due to prevailing malnutrition in our population. So if you see the prevalence of iron deficiency anemia across different tumors, So if you see on the left side of this line, these are several tumors like pancreatic, colorectal, and you can see the extent that is around 30 to 40% from GI to colorectal to gynecological, even testicular and breast. Later down the stages may have iron deficiency anemias, and definitely hematological malignancies. These patients do suffer from this problem. So other than that, it can be multifactorial causes as well. It can be nutritional deficiency, hemolysis, blood loss, infiltration of bone marrow by tumor cells, and myelosuppressive effect of chemo and radiation therapy. Then we have anemia of chronic illnesses, which can be due to infection, inflammatory, or renal failure. So what are the consequences of this anemia? It does lead to compromised quality of life. There is fatigue, poor performance status, impaired cognitive function, aggravating of coexisting comorbidities like respiratory and cardiovascular illnesses, and premature death. So how do we grade anemia? There is an anemia scale which has been defined by National Cancer Institute. And what it says is that mild ranges from lower limit of normal to 10. From 10 to 8, it is moderate anemia. From 8 to 6.5, it is severe anemia, and less than 6.5 is life-threatening. So this is a list or a compilation of drugs which we use in our practice, and often these drugs are the causative agents and culprits in causing anemias. So most of these tumors belong to alkylating agents, or they can be anti-tumor metabolites. So we oftenly use these agents, and we found that these agents do cause anemia, mostly grade 1 and 2, and sometimes grade 3 and grade 4. So who are the patients who are most likely to develop this anemia? It's mostly older patients, patients who have had baseline hemoglobin of near lower limit of normal, and who've been planned for a very myelosuppressive form of chemotherapy, patients who have had transfusions or bleeding history in last 6 months, and patients who have had radiation therapy to more than 20% of the bones. So how do we approach such patients? So this is the NCCN guidelines, which tells us how to approach such patients. So initially, you need to do a check on reticulocyte count and do a mean corpuscular volume. And then you need to see the other forms of other causative agents like a hemorrhage or a hemolysis or a nutritional cause or an inherited cause. It could be renal dysfunction, it could be radiation, induced myelosuppression, hormonal dysfunction, anemia of chronic inflammation. So these are a few stores that we need to see. It could be serum ferritin from serum ferritin to TIBC to serum iron and transferrin saturations, and that is how we segregate them into. If everything is normal, it is a normal iron store. If serum ferritin is low, we put the patient into negative iron balance. If serum ferritin is low but other parameters are high, TIBC is high, patient has poor erythropoiesis, and if this is low and transferrin saturation is low, patient goes into iron deficiency anemia. So this is another set of guidelines from NCCN, which suggests that if the patient is asymptomatic without any significant comorbidities, we need to observe, treat the patient accordingly. In case of high risk, the patient has a progressive decline in HB, then the American Association of Blood Bank guidelines do suggest that patient should be given a red blood cell transfusion. Again, asymptomatic with comorbidities, cardiac patients having cardiac diseases, chronic pulmonary and vascular cerebrovascular diseases, red blood cell transfusion is advocated. So what are the benefits of RBC transfusion? Definitely it increases the hemoglobins immediately. There is a rapid symptom control, and patients can avoid the risk of erythropoietin stimulating agents. However, there are certain risks associated with RBC's transfusion, like thrombotic events, transfusion, transmitted diseases, congestive heart failures, transfusion-related lung injuries, graft versus host disease, contamination, and so forth, so on. So which preparations or formulations we should be using? So NCCN gives a list of all these preparations. However, what is most oftenly used is ferric carboxy maltose, and it does require a testing dose, but that is at the treating doctor's discretion, and it requires pre-medication, and this is the standard dose which needs to be given to patient. It is at 15 mg per kg of body weight for patient less than 50 kg, and the repeat dose is given once at least 7 days later, and total dose should not exceed 1500 milligrams. So how do we approach a patient of anemia? So this is algorithmic representation. Patients who have had HB of less than 8 and require a rapid HB transfusion, they should be given RBCs immediately. The patients who have a HB of 8 to 10, we need to ascertain the vitamin B12 and folate deficiency. If it is low, we need to replenish these stores. In case these are fine, we need to do a serum ferritin or a transferrin saturation. So this will help us to define patient whether they have an absolute iron deficiency or a functional iron deficiency. An absolute iron deficiency is defined as a serum ferritin of less than 100 nanogram per ml, and therefore you have to give an IV iron to such patients. In case hemoglobin still remains low, less than 10, you need to add an erythropoietin stimulating agent. A functional iron deficiency is when you have a normal serum ferritin, but still transferrin saturation is less than 20. So in such patients, ESA agent is advocated. In patients who have normal transferrin saturation and normal serum ferritin, erythropoietin stimulating agent with an IV iron is usually advocated. For patients with HB of 10 to 11, you again need to see whether it is iron deficiency, give IV iron. In case it is vitamin B12 and folate, replenish them. Or if there are anemia of other causes, you need to treat the underlying condition. So whether you give an oral or an IV iron, definitely IV iron is better. Oral iron has been shown to alter the dominant gut bacterial communities and exacerbates colonic or ileal inflammation. So what all parenteral iron therapies do we have? So this is a timeline of various intravenous iron therapies from 1932, which is ferric hydroxide. Then came iron saccharide, and these preparations were there in 1990s and 2000s. You had iron sucrose, and now you have ferric carboxymaltose and iron isomaltoside. So if we need to divide them into first, second, and third generation. So before this ferric gluconate were the first generation, iron sucrose came into the second generation, and ferric carboxymaltose is the third generation intravenous iron preparation. So this is a conceptual structure of ferric carboxymaltose. It has an iron core and it's surrounded by carboxymaltose shell. It's a stable and robust complex. And it is quite efficacious, as can be shown into this bar diagram, that patients pre-FCM, and this was the hemoglobin around 11, and after 6 weeks of treatment, the hemoglobin rose to 13. So it is quite efficacious, and it has been shown to effective in all sorts of anemia, whether it is mild, moderate, or severe anemia. And again, if you compare a ferric carboxymaltose versus oral iron therapy, definitely FCM is a better choice, as can be seen in this representation. So the patients who have had 0-0 response at the end of day 21st, it was 45% for oral iron and 85% for FCM. Again, at the end of day 42, it was 61% for oral iron and 100% for FCM. So FCM definitely is better in terms of response. Comparing FCM with iron sucrose, the second generation intravenous iron, again, these are head-to-head with the FCM slightly edging past the iron sucrose preparations. Again, FCM has this benefit that it requires lesser IV transfusions. So there are certain adverse reactions associated with intravenous irons, and we will be having a glance at them at the later slides. There are certain advantages. The patients will have fewer clinical visits. There is improved patient compliance. Patient can preserve venous access, reduction of blood transfusions, and you, of course, save on the cost. So if we need to quantify the iron FCM preparation, the ferric carboxymaltose preparation, so this is where it lies. It is much lower in terms of toxic effects of levyl iron and definitely in terms of immunogenicity. So it is quite low in terms of toxic effects and as well as immunogenicity, and this is where iron sucrose lies. So ferric carboxymaltose scores past the other preparations. Of course, these side effects are there with this preparation. So what is the clinical data on FCM? There are several studies which have actually cemented the role of FCM, and these have been several small and large studies, and this was one study by Steinmetz, and it suggested that there was a substantial increase in HB and stabilization at 11 to 12 gram in patients who had received IV ferric carboxymaltose. Again, this was an observational study suggesting the same outcome. It has been also tried in patients who have undergone surgery, and this was again one study where preoperative carboxymaltose had shown that patients with cancer, cachexia, and iron deficiency anemia have significantly reduced RBC transfusion and hospital length. So again, leading to better responses, better patient outcomes. So I think this is the same conclusion from a different study. So these are several studies that have compared ferroxy carboxymaltose with iron sulfate, and again, all these studies, these were used in different conditions: inflammatory bowel disease, uterine bleedings, postpartum IDS, in kidney diseases, and patients undergoing dialysis. The FCM preparation stood better. So I think this is my last slide. If you compare FCM versus ferrous sulfate, definitely the oral ferrous sulfate preparation has more GI side effects. in terms of nausea, constipation, diarrhea, vomiting, and abdominal pain. So ferric carboxymaltose is a good preparation. It helps you to improve the performance status of the patient, and that would achieve a better outcomes in your patient. So I think I'll stop here. Thank you all for your patient hearing.
Thank you, Dr. Samit. Hello.
Yeah, thank you. Thank you, Sujat.
Thank you, sir. Thank you for giving us a in view of chemotherapy-induced anemia. I would now like to invite Dr. Pravas Mishra. He's a senior hemato-oncologist at Max Hospital, and he has done from a prestigious institute, AIMS. Sir, over to you for your topic.
Thank you. Right. My screen is visible again?
Yes, sir.
Thank you. So I will be talking about tailoring. Just a minute. I'll just minimize some of the screens here. Okay. So I'll be talking about tailoring first-line treatment in chronic lymphocytic leukemia with comorbidities. I'm Dr. Pravash Mishra from Max New Delhi. So we don't have much data on chronic lymphocytic leukemia in India. So we have this data which says that it is not very common as compared to other leukemias, less than 5% of all leukemias. The incidence rate of chronic lymphocytic leukemia is 0.41 per 1 lakh, which is almost 10 times lower than that in the United States. And as we have heard several times, and what is our experience as well, is that compared to the Western population, most of our patients are younger. They quite often they might have a poor performance status, and many patients have got adverse prognosis, and some patient might have adverse prognostic markers at presentation. So this is what has been put up, and the treatment options that are available to our patients are the chemoimmunotherapy regimens like FCR, BR, rituximab, chlorambucil. Now we are coming up with obinutuzumab, and then the newer Bruton tyrosine kinase inhibitors, including ibrutinib and acalabrutinib. So most of the literature on CLL is available to us from the Western world. That is where we derive most of our information from. There is very little data from India. We have this data from PGI. So the upper paper, both the papers have been published by them. The upper one is abstract. The one below is the complete paper. So they presented the data on 409 patients over a period of 5 years, and out of which 58.7% received treatment and 140 patients remained on observation. The median age in this population was 61 years, 31.8% were 55 years or younger, and the patient fitness was poor, as defined in this particular group of patients as more than or equal to 3 in 43.3% of the cases. More than 40% of the patients had advanced stage CLL, and the incidence of autoimmune cytopenias was somewhat higher in this group of patients as compared to data from the Western world, with most of for 22% having autoimmune cytopenias could be either anemia or thrombocytopenia, with a majority of these patients being autoimmune hemolytic anemia. So in these patients, they gave 31.6% of the patients received bendamustine rituximab with an overall response rate of 91%, and time to next treatment was not reached. Chlorambucil was used in 52.2% of these patients, overall response rate of 73.9%. Treatment time to the next treatment was 33 months. Second line treatment, bendamustine rituximab and rituximab chlorambucil regimens were used with an overall response rate of 88%. Time to next treatment was 42 months for bendamustine rituximab and not reached. There appeared to be this trend, so it was not significant for the rituximab chlorambucil arm. In these patients, only 10% of the patients received the novel agent ibrutinib because of cost constraints. They might have had a few more patients recently on ibrutinib since the generic ibrutinib was available. At least it is available till now. Perhaps it will not be available in the future. So when we are talking about our patients, the way we want to treat them, so we have these four groups of patients: younger, fit, untreated CLL patients, older patients or patients with comorbidities, relapsed refractory chronic lymphocytic leukemia patients, and CLL patients with 17p deletion. So we would be perhaps be concentrating on this group of patients, older patients or patients with comorbidities. But to initiate the discussion, this is the phase 3 CLL8, where they compared fludarabine chlorambucil versus fludarabine chlorambucil rituximab in patients with active CLL. And the primary endpoint in this group of patients was the progression-free survival. So the progression-free survival in the FCR group was better as compared to the fludarabine cyclophosphamide arm, and the overall survival was also better. So this was the data was similar for whether it was less than 65 years of age or more than 65 years of age. Overall survival, progression-free survival, CR rates, and overall response rates were all similar. However, in the FCR group, as compared to the other one, there were significant differences in terms of hematological toxicity, neutropenias, leukopenias, thrombocytopenias. The rate of infections between the two groups were not very significantly different. This was the phase 3 CLL 10 data. This was the data on FCR versus bendamustine rituximab. Here again, the primary endpoint was non-inferiority of bendamustine versus FCR for progression-free survival. And in this group of patients, again, though the FCR had seemed to have a better progression-free survival as compared to bendamustine rituximab, the overall survival at 36 months was not significantly different. So the adverse events with FCR versus bendamustine rituximab, again the neutropenia was more with the FCR arm, and the thrombocytopenia, there also seemed to be a trend towards more thrombocytopenia in the FCR arm, more infections in the FCR arm as well. And therefore, for this reason, in younger fit patients with CLL, you could have a combination of rituximab either in combination with fludarabine cyclophosphamide or bendamustine rituximab. In fact, most of my patients would receive bendamustine rituximab for the reasons depicted in the previous slide. Coming to the older people. Now, older people, we don't do a reasonable frailty assessment when we are looking at older people. This is data again from Western population, where the median age, as you can see, in almost all hematological malignancies is 60 plus, except for the acute lymphoblastic leukemia. Here, in patients with chronic lymphocytic leukemia, their median age is 70 compared to a decade younger in our group of patients. And in these group of patients, again, 30% of the patients were 65 to 74 years of age, and significant numbers of patients again in the older age group. So frailty assessment is extremely important when we are planning therapy. This slide further depicts why we need to look at frailty. So the bottom part is the normal aging process. So, we become frail over a period of time because of senescence of the cells and organs. Various organs of our body, they start to decline in strength and function as a normal course. Now, in addition, after this, as we grow older, there is a build-up. You can see there is a frailty build-up, and that it doesn't take much for this frailty to build up. So, as we grow older, over a period of time, we also add various comorbidities. So, we have got heart diseases, we have got osteoarthritis, diabetes, and we start popping in several pills and drugs, exposure to environment. So all of this also adds to the frailty, and soon we have crossed a threshold beyond which we just have to tip over. And once we have a cancer, the frailty simply the frailty in the individual simply goes up. So we have got anemia, which results in weakness, immunosuppression resulting in increased infection and fatigue, tumor pain resulting in pain-related postures, sarcopenias, reduced movement, bad nutrition. So even if you do not have any of these problems, let us say there is a fit elderly gentleman who is just here, even if you just add one malignancy, he immediately goes, the frailty immediately goes up. And on top of it, we will add to that frailty by our medication. So our aim is not to add to the frailty due to the therapy. So you could have treatment which could cause myelosuppression, more infection, more fatigue, mucositis, reduced food intake, neurotoxicity, polyneuropathy, and weakness and falls. So our aim is to reduce this particular aspect of frailty. And how do we go about doing it? So there are several ways in which you can calculate the frailty, and for one of the commonly used frailty indexes is the cumulative illness rating scale. You can use various online tools to calculate the frailty in your patient, and this is true for not just chronic lymphocytic leukemia. You might like to use it even for other malignancies. So this is a CLL 11 study. They use the CIRS score that I described earlier, where if it was more than 6 or a creatinine clearance of less than 70 was considered to be frail. So in this group of patients, they compared these three interventions. So either you give chlorambucil. In fact, this is most commonly used even in our country for frail individuals, compared with obinutuzumab with chlorambucil for 6 cycles, or rituximab chlorambucil for 6 cycles. So in this group of patients, they found that combining obinutuzumab or Gazyva, as it is known, with chlorambucil gave significant complete responses and partial responses as compared to, obviously compared to chlorambucil, but also in comparison to rituximab chlorambucil. So this is progression-free survival data from this study, where they show that the Gazyva chlorambucil arm had a significantly improved progression-free survival as compared to the chlorambucil arm. Also, in compared to the rituximab, so this is the rituximab chlorambucil, which also has a significant improvement in progression-free survival. And I don't have the chart for the comparison between Gazyva chlorambucil and rituximab chlorambucil. But even if you look at these two slides and you superimpose them, you will find that the Gazyva chlorambucil arm seems to have a better progression-free survival. This is the overall survival data. I had data on this particular study till April 2014. So till then, there was no significant differences in the overall survival. Even up till May 2015, they had presented their data. They did not have significant improvement in overall survival. But once in I think 2018, EHA, they presented updated data on this particular trial. And now after nearly 4 years of treatment, they started to find that the overall survival is better in those patients who received obinutuzumab as compared to the rituximab chlorambucil arm. Importantly, the time to next anti-leukemic treatment. So this is important because once you're on one particular line of therapy, so if you keep on changing therapies, that reduces the quality of life. So the time to the next anti-leukemic treatment in the Gazyva chlorambucil arm was significantly better as compared to the rituximab chlorambucil arm. So the median time to the next anti-leukemic treatment in the rituximab arm was approximately 3 years as compared to about 4.5 years, 5 years with the Gazyva arm. Even MRD. So MRD, there is significant reduction. There is significant proportion of patients achieve a MRD negativity either in the peripheral blood or in the bone marrow in the Gazyva arm as compared to the rituximab chlorambucil arm. The most frequent reaction that was seen compared to the rituximab arm, the Gazyva chlorambucil arm seemed to have more of infusion reactions, but otherwise the rest of the adverse effects were fairly comparable. So most of these infusional reactions seem to occur in the first infusion, and they were infrequent after the first infusion. So these are the several chemoimmunotherapy studies that are currently, which have been currently published in elderly CLL. We have got the MABEL, that is bendamustine rituximab, green, that is so this is G-benda. Then we have got Gazyva chlorambucil, this is CLL 11 arm, and we have got the ofatumumab, chlorambucil, this is a complement arm. So all of these have been published, and you can see that much of this has been done. For example, the green, the CLL11 and the complement, they have used patients who are exceedingly frail. And in this group of studies, the only study that has had some survival benefit is the CLL11 arm, which used Gazyva with chlorambucil. So if you've got an older patient or patient with comorbidity, then the drug to use would be either ibrutinib or obinutuzumab with chlorambucil if the ibrutinib is not available or not tolerated due to any of the side effects. In patients who have got a deletion 17p, we do find the responses. However, these responses are shorter progression-free survival, and there is a pattern of continuous relapses. This deletion 17p is associated with several other complex chromosomal karyotypes, and overall, this particular mutation has been associated with an inferior outcome in treatment naive or relapsed refractory CLL. So these are various studies that have looked at it, and if you see among all the other mutations, the least survival is in deletion 17p, and also this is the same that has been studied in various other groups as well. So probability of overall survival, progression-free survival is exceedingly poor if you have got a deletion 17p. And in this group of patients, this is the phase 3 resonate, where they compared ibrutinib versus ofatumumab in previously treated CLL patients with this particular deletion. As you can look here, that most of these patients were otherwise fit. These were not frail patients. And in this group of patients, ibrutinib had a significant improvement in progression-free survival and also overall survival as compared to the other arms. So if you have got a 17p deletion, treatment naive or relapse, then ibrutinib would be the way forward. There are several other novel combinations. So we have got obinutuzumab plus ibrutinib. So the idea is that we are trying, as in various other hematological malignancies, we are trying to move away from a chemotherapy. So we are trying to look at chemotherapy-free regimens. So the ibrutinib, obinutuzumab, obviously here again, progression-free survival is very good, even in patients with a bulky disease. This is the Illuminate study. And then we have got the Elevate TN study, which was studying achelabrutinib with Gazyva, again showed a significantly improved progression-free survival, either even combination with obinutuzumab or even alone. They seem to be much better as compared to the chlorambucil arm. This is the CLL14, where patients with untreated CLL and coexisting conditions, so they have used venetoclax in combination with Gazyva. So they found that venetoclax obinutuzumab arm was significantly better in terms of progression-free survival. I would be interested in knowing what other people, how they, if at all anybody has used venetoclax in these group of patients. And when I mean venetoclax, I mean the founder product and not one of the not the non-generic products which are available currently. These are the current treatment recommendations. So we have got fit patients and unfit patients. You can use pretty much, you can put ibrutinib everywhere and this would be fine. But in those where you don't have access to ibrutinib, then in fit patients with without the TP53 mutation, you can use bendamustine rituximab. And in unfit patients, you can use combinations of venetoclax obinutuzumab, chlorambucil obinutuzumab, or combinations with rituximab. And in those patients who are IGHV unmutated and do not have the TP53 mutation, and you don't have access to ibrutinib, then bendamustine rituximab in patients who are fit, and similar combinations in unfit patients. Whereas if you have got the TP53 mutation, then you can use either ibrutinib or venetoclax monotherapy or venetoclax in combination with obinutuzumab or achelabrutinib or idelalisib rituximab. We don't have much data anymore on idelalisib. So in relapsed refractory patients where they got TP53 mutation, which is if it is absent in relapsed refractory, again, if you have not used some of the other molecules, then you can use them. The same holds true for patients who have got TP53 mutation. It's almost essentially the same. So these are the NCCN guidelines. One of the interesting combination that I have used previously when we did not have some of the newer molecules was high dose methylprednisolone with rituximab. Again, lot of infection complications in this group of relapsed refractory where we have used high dose methylprednisolone. So to conclude, definitely rituximab has revolutionized, as it has revolutionized for other lymphomas, B-cell lymphomas, the treatment of CLL. So there are various now newer options are available, such as obinutuzumab, or patient with 17p deletion, you can use ibrutinib. So this appears obinutuzumab chlorambucil combination could be used for patients who have got comorbidities, and those patients who have got a 17p deletions, you would use ibrutinib. Thank you.
Thank you, Dr. Pravas. It was a very lucid presentation, and especially in our setting when we have a lot of patients who have comorbidities, I think that is the way forward. So thank you, sir.
Yep, thank you.
So I think with this, we'll move on to the next lecture for today. That would be by Dr. Rahul Bhargav. And I think we still have time for him to join, and he'll be speaking on ultramopagan management of aplastic anemia. So meanwhile, we can play the slides, or we can play the Sparsh slides. And I would request the organizers actually to just call Dr. Rahul Bhargav and see where he is.
आपने बोल दिया आप आगे
Okay. Yeah. Hello.
Sir, good evening.
Good evening. Yes. Should I start?
Yeah, sir. Sure, sir. Go ahead.
Okay. So, hi friends. Sorry for being late. I think the most important revolution which has taken place in the field of aplastic anemia. So, can you see me? Can you see the screen?
Not yet.
Can you see that?
Yeah. Yes, sir.
Perfect. So, friends, what PT-Psi did for Haplo, Eltrambopac has done for aplastic anemia. A GSK product, I remember in 2012 and 2013, GSK selling it to Novartis, which was for chronic hepatitis C. And with the oral medication coming by, GSK lost its interest because it was hepatitis C was the biggest indication for Eltrambopac, because we remember that thrombopoietin comes from liver, and liver was failing in hepatitis C, and they used to give interferon. And that's a history where it was picked up from GSK to Novartis, and Novartis did its best to do the research for ITP, because we got an understanding in 2013 and 2014 that it is just not the production, just not the destruction, but the production is also at fault. And then comes the seminal papers on aplastic anemia, which was prohibitively expensive. And then in 2020 comes, or 2021 comes the generic product, thanks to our Indian companies for providing Eltrambopac, because it could solve many problems for aplastic anemia. And our rates of Eltrambopac with aplastic anemia hitting at 88% with ATG. Somebody said last time that a pediatric transplanter, they said pediatric cases need to go for a haplotransplant. And I said, no, if you give ATG plus Revolade, it brings in a lot more sanity, much more easier, and the 40% risk for mortality with an upfront haplo in aplastic anemia cannot be justified. And this patient did well. So aplastic anemia is not a rare disorder. It is one of the commonest disorders in India. We used to see 300 patients on an odd Friday, when Western world by 5 o'clock managed to go for weekend, and we were struggling to see how painful the death could be, because these people were falling left, right, and center because of virtue of fungal infections and so on and so forth, and waiting for the grants to come by. Epidemiology-wise, half of completed. A occurs in the first 3 decades of life. The sex ratio is close to 1:1. There's no changes. And majority of patient comes to us from Bihar, Uttar Pradesh, Jharkhand, and so on and so forth, because of the pesticides, probably because in the environment, because of the viruses. We still don't know. And Dr. Rishi has got a grant of $150 million, $150,000 for deciphering why India gets more of aplastic anemia. And the only way to know is bone marrow aspiration and biopsy. And unfortunately, in many places of Uttar Pradesh and Bihar, the biopsy is not done. It's just made on aspirate, and people come to us, they are either leukemia or something else. And of course, the differential diagnosis remains between aplastic anemia and MDS. And we know about the pediatric age group where the stress cytogenetics, we have moved on to the genomic studies for inherited bone marrow failure syndromes. And these are the immune aplastic anemia syndromes where you need to rule out PNH and so on and so forth. So how do we treat acquired aplastic anemia? Is plain and simple, friends. Very, very simple. Either once the patient is being diagnosed in your periphery, please start them on cyclosporin and Revolade. Cyclosporin 50 mg BD and Revolade at least 150 milligram in adult side and 100 milligram in pediatric age group, because it's been approved beyond 2 years of age. So that by the time they reach to any quaternary structure like AIMS, SGPGI, Lucknow, and so on and so forth, at least they have some stem cells which are alive to be taken care of. And this is how you treat less than 45 years. The first and the best chance is bone marrow transplant. But if you don't have a match, you don't go for or don't wait for a MUD or a haplo you give ATG to these people before the stem cells gets wiped out. One caveat, in pediatrics up to 18 years of age, mud can be utilized, but please understand, mud people, while waiting for mud, people have died. So if you can't get a mud within 15 days, it's not America. It is very easy to see the guidelines and say, wait for mud, people die. We have lost people waiting for a mud from various tertiary hospitals. Please do not wait. The simple algorithm is cyclosporin plus Revolade, if nothing else. Best bet up to 45 years is bone marrow transplant, and beyond 45 years of age, it is ATG plus cyclosporin and Revolade or Eltrambopac up to age of up to 6 months. And this is what the frontline BMT shows. This we could have shown our own data, which is like sitting at 90-95% over a 10-year span, and they're doing very well at this present moment of time. Unrelated donor transplant is improving upon, and we know those things are becoming better and better and better. We also do understand, but we have just recently had a bad case with a mud transplant. So you need to understand, MUDs are not that easy until unless you are having a run of a mill. Then it's fine, but once it complicates, it really gets complicated. First line IST, immunosuppressive therapies, people will say 30% for pediatric, ours sitting at 70% plus with usage of Eltrambopac and this. So supportive care is what we require. Long-term Eltrambopac can cause iron deficiency due to iron chelation problems, but yes, up to 6 months to 1 year is required. Moderate aplastic heterogeneous category, exclude inherited bone marrow failure syndromes, generally start when there's ongoing transfusion support and lifestyle is affected. Moderate aplastic anemia, immunosuppressive horse ATG is better than the rapid ATG. Infused through central lines, we know. Prednisolone prophylaxis is only for serum sickness. You don't give prednisolone for aplastic anemia. Aplastic anemia, if you treat with a prednisolone, you kill the patient. It's as simple as that. You don't do anything, you just kill the patient. So I think that's what the more important thing. Cyclosporin is 3 milligram per kg body weight, which needs to be given, and you have to maintain the cyclosporin level. So major complication, what you see is renal toxicity and hyperkalemia and hirsutism. But please understand that fact that cyclosporin levels needs to be checked. So majority of centers don't do that. Yes, whosoever is giving ATG needs to check the cyclosporin level. And the triple response, triple IST, horse ATG plus cyclosporin and Eltrambopac has increased the CR rates, overall rates to 90% and CR rates from poultry 15% to 50%. That's huge. And this is a paper which has come over from Eltrambopac added to standard line, which has been published in NEGM, and which shows a huge response rate. And up to 6 months, it has to be given. The bone marrow cellularity has shown CD34 counts have become better. This is from an NEGM 92 adults with triple IST achieved a 97% 2-year survival. Relapse rate for poultry at 15%, rate of relapse in colon evolution was similar. There was no other problems with that. So triple IST 2 years cyclosporin maintenance was better than 6 months of cyclosporin. Reduced and delayed relapses in these courses. Eltrambopac began on day 1, continued for 6 months. So when do you start? The moment you start ATG, you start giving 150. The only thing which you have to worry about is the rising liver enzymes, because we use quite amount of antifungal prophylaxis as well. Outcomes with ATG has becoming better and better. Response in 1/3 was historical controls. You can see overall response rate 65 jumping 90% and CR from 10% to 15% going up to almost 50%. So there was no use of single GCSF, which was there. Eltrambopac, severe aplastic anemia has got a immune responses, and people have done very well. So Eltrambopac has become the backbone of aplastic anemia treatment at this present moment of time. So Eltrambopac has got a huge role, and another role which has comes in the ITP, which it keeps on stimulating the TPO receptor agonist, which increasing of not only on the platelets, but at the megakaryocytes, but at the stem cells also. Potential role for Eltrambopac to augment responsiveness to ATG and cyclosporin. And this is where things looks like Eltrambopac for patients with moderate severe aplastic anemia. These are the response rates. As we know, there's no increase in clonal evolution. So we are worried about clonal evolution. No. Clonal site was rare with no instance of chromosomal similar abnormalities. So it's a safe drug which can be utilized. Lower intensity CS monotherapy in moderate, overall response 46%. With Eltrambopac, it has increased to next stage. RAISE design was horse ATG with cyclosporin and Eltrambopac with isolated with immunosuppressive alone in patients with severe aplastic anemia. And we know the response rates were pretty much good at this present moment of time. Detect an increase, and which shows Overall, at 6 months, arm A 44%, arm B was 71.8%, and odd ratio was 3.7%. Eltropopac improved hematopoiesis in refractory aplastic anemia as well, people who have received. And these are various papers to prove the effect of even romiplastin has been utilized in this conclusion. So what is happening is that TPO receptor agonists are going up. Romiplastin is still, we have used in a couple of patients, not found to be great. But yes, Eltropopac with a generic one available, I think every aplastic anemia deserves to get that because the cost of or Eltropopac has really come down. And it restores trilineage hematopoiesis, useful as salvage therapy, preliminary, very good response added to IST in frontline, good tolerability, results from ongoing provider robust data. With this, we come to an end. Our own data of 20 patients till now has a 92% success rate. So I think it's a drug to be utilized very well. And even if you, by the time your patient is waiting for aplastic anemia treatment, we really need to use this before the stem cells get piped out, and there's nothing to stimulate that. With this, we come to an end. I hope we will be saving much more lives in aplastic anemia. Thank you.
Thank you, Dr. Rahul. Definitely, that was a showstopper presentation from you. And thank you, sparing time. I know it's a busy Saturday evening for you. With this, we come to the end of day 2 of our hematology updates. So I would like to just extend my thanks to all my speakers, my moderators, and my panelists. And I would like to thank my sponsors as well. So it's a good night from my side. Stay safe and be safe. Thank you.